let's talk about sodium and other ion imbalance, specifically with a focus on sodium and its associated anions, chloride and bicarbonate, which are the major solutes of the extracellular fluid. In turn, the amount of sodium in the ECF determines the ECF volume. Consequently, an increase in the amount of sodium more than 145 milliequivalents per liter is hypernatremia and leads to an increase in ECF volume, and blood pressure. A decrease in the amount of sodium below 135 milliequivalents per liter, which is hyponatremia, leads to a decrease in ECF volume, and blood pressure. A useful concept for understanding the regulation of sodium balance is that of effective arterial blood volume, or EABV. EABV is that portion of the extracellular fluid volume contained in the arteries and is the volume effectively perfusing the tissues. In general, changes in ECF volume lead to changes in EABV in the same direction. For example, increases in ECF volume are associated with increases in EABV, and decreases in ECF volume are associated with decreases in EABV. There are exceptions, however, such as edema, in which an increase in extracellular fluid volume is associated with a decrease in effective arterial blood volume due to excessive filtration of fluid out of the capillaries into the interstitial fluid. The kidneys detect changes in EABV and, through a variety of mechanisms, direct changes in sodium excretion that attempt to restore EABV toward normal. The renal mechanisms that regulate sodium excretion include sympathetic nerve activity, atriopeptin, or ANP, Starling forces in peritubular capillaries, and the renin-angiotensin-aldosterone system, as follows. First, sympathetic nerve activity. Sympathetic activity is activated by the baroreceptor mechanism in response to a decrease in arterial pressure and causes vasoconstriction of afferent arterioles and increased proximal tubule sodium reabsorption in the kidney. Atriopeptin, or ANP. ANP is secreted by the atria in response to an increase in ECF volume and causes vasodilation of afferent arterioles, vasoconstriction of efferent arterioles, increased GFR, and decreased sodium reabsorption in the late distal tubule and collecting ducts. Other peptides in the ANP family have similar effects to increase GFR and decrease renal sodium reabsorption. These include urodilatin, which is secreted by the kidney, and brain natriuretic peptide, or BNP, which is secreted by cardiac atrial cells and the brain. Starling forces. Starling forces in the peritubular capillaries. Briefly, increases in ECF volume dilute the colloid osmotic pressure in the capillary and inhibit proximal tubule sodium reabsorption. Decreases in ECF volume concentrate the colloid osmotic pressure in the capillary of the peritubular capillary bed and stimulate proximal tubule sodium reabsorption. Lastly, the renin-angiotensin-aldosterone system. The RAA system is activated in response to decreased arterial pressure, that is, decreased renal perfusion pressure. Angiotensin II stimulates sodium reabsorption in the proximal tubule, specifically through the sodium-hydrogen exchanger. And aldosterone stimulates sodium reabsorption in the late distal tubule and the collecting duct. Two examples are shown here that will be considered in which these mechanisms are employed to restore sodium balance: the response of the kidneys to increase sodium intake and the response of the kidneys to decrease sodium intake. In the top picture, you see the four ways the body responds to increased sodium intake. When a person eats a high sodium diet, because sodium is primarily distributed in the ECF, there is an increase in ECF volume and EABV. The increase in EABV is detected, and the kidneys orchestrate an increase in sodium excretion that attempts to return ECF volume and EABV to normal. In the bottom picture, we see how the body responds to decreased sodium intake that leads to hyponatremia, which is a plasma concentration of sodium below 135 milliequivalents per liter. When a person eats a low sodium diet, there is a decrease in ECF volume and EABV. The decrease in EABV is detected, and the kidneys orchestrate a decrease in sodium excretion that attempts to return ECF volume and EABV to normal. The following key principles are necessary to understand fluid shifts between the body fluid compartments. Learn and understand these principles. The volume of a body fluid compartment depends on the amount of solute it contains. For example, the volume of the extracellular fluid is determined by its total solute content. Since the major cation of the extracellular fluid is sodium and its accompanying anions, chloride and bicarbonate, ECF volume is determined by the amount of sodium chloride and sodium bicarbonate it contains. Osmolarity is the concentration of osmotically active particles, expressed as milliosmoles per liter. In practice, osmolarity is the same as osmolality, milliosmoles per kilogram of solvent. Since 1 liter of water is equivalent to 1 kilogram of water, we can use these terms interchangeably. The normal value for osmolarity of the body fluids, as I've been telling you, is approximately 290 milliosmoles per liter, or for simplicity, a lot of textbooks round up to 300. Plasma osmolarity can be estimated from the plasma sodium concentration, plasma glucose concentration, and blood urea nitrogen, as these are the major solutes of the extracellular fluid and plasma. Where the sodium concentration is multiplied by 2, as we discussed, because sodium must be balanced by an equal concentration of anions. In plasma, these anions are chloride and bicarbonate. The glucose concentration is in milligrams per deciliter and is converted to milliosmoles per liter when it is divided by 18. The bun in milligrams per deciliter is converted to milliosmoles per liter when it is divided by 2.8. In the steady state, intracellular osmolarity is equal to extracellular osmolarity. In other words, osmolarity is the same throughout the body fluids. To maintain this equality, water shifts freely across cell membranes. Thus, if a disturbance occurs to change the ECF osmolarity, water will shift across cell membranes to make the ICF osmolarity equal to the new ECF osmolarity. After a brief period of equilibration, while the shift of water occurs, a new steady state will be achieved, and the osmolarities again will be equal. Solutes such as sodium chloride, sodium bicarbonate, and large sugars such as mannitol are assumed to be confined to the extracellular fluid compartment because they do not readily cross cellular membranes. For example, if a person ingests a large quantity of sodium chloride, like I did last night at the Mexican restaurant, the sodium chloride will be added only to the extracellular fluid compartment and the total solute content of the ECF will be increased. 6 disturbances of body fluids are summarized in the figure above and on the table on the next page or slide. Both this slide and the next are showing you the same things, just in different formats. The disturbances are grouped and named according to whether they involve volume contraction or volume expansion, and whether they involve an increase or decrease in body fluid osmolarity. Volume contraction means a decrease in extracellular fluid volume. Volume expansion means an increase in ECF volume. The terms isoosmotic, hyperosmotic, and hypoosmotic refer to the osmolarity of the ECF. Thus, an isoosmotic disturbance means that there is no change in ECF osmolarity. To understand the events that occur in these disturbances, a three-step approach should be used. First, identify any change occurring in the ECF. For example, was solute added to the ECF? Was water lost from the ECF? Second, decide whether that change will produce an increase or decrease or no change in ECF osmolarity. No change is isoosmotic. Increased means hyperosmotic. Decreased means hypoosmotic. Third, if there is a change in the ECF osmolarity, determine whether water will shift into or out of the cells to reestablish equality between the ECF osmolarity and ICF osmolarity. If there is no change in ECF osmolarity, no water shift will occur. If there is a change in ECF osmolarity, then a water shift must occur. For the sake of the transcript, I will discuss all 6 of these conditions, but scattered between this slide and the next one. Let's discuss isoosmotic volume contraction, like diarrhea. A person with diarrhea loses a large volume of fluid from the gastrointestinal tract. The osmolarity of the fluid is approximately equal to that of the extracellular fluid, that is, it is isoosmotic. Thus, the disturbance in diarrhea is a loss of isoosmotic fluid from the ECF. As a result, ECF volume decreases, but there is no accompanying change in ECF osmolarity because the fluid that was lost is isoosmotic. Because there is no change in ECF osmolarity, there is no need for a fluid shift across cell membranes, and ICF volume remains unchanged. In the new steady state, ECF volume decreases, and the osmolarities of ECF and ICF are unchanged. The decrease in ECF volume means that blood volume, a component of the extracellular fluid, also is reduced, which reduces a decrease in arterial pressure. Other consequences of diarrhea include increased hematocrit and increased plasma protein concentration, which are explained by the loss of isoosmotic fluid from the ECF compartment. The red blood cells and proteins that remain behind in the vascular component of the ECF are concentrated by this fluid loss. This is shown in the top picture with volume contraction on the left side, where it says diarrhea. That would be an isoosmotic volume contraction. Hyperosmotic volume contraction with water deprivation, top middle picture. A person who is lost in the desert without adequate drinking water loses both sodium chloride and water in sweat. A key piece of information not immediately obvious is that sweat is hypoosmotic relative to extracellular fluid. That is, compared to the body fluids, sweat contains relatively more water than solute. Since a hypoosmotic fluid is lost from the ECF, ECF volume decreases and ECF osmolarity increases. ECF osmolarity is transiently higher than ICF osmolarity, and this difference in osmolarity causes water to shift from ICF into ECF. Water will flow until ICF osmolarity increases and becomes equal to ECF osmolarity. This shift of water out of cells decreases the intracellular fluid volume. In the new steady state, both ECF and ICF volumes will be decreased, and ECF and ICF osmolarities will be increased and equal to each other. In hyperosmotic volume contraction, the plasma protein concentration is increased, but the hematocrit remains unchanged. The explanation for the increase in plasma protein concentration is straightforward. Fluid is lost from the ECF, and the plasma protein remaining behind becomes concentrated. It is less obvious, however, why the hematocrit is unchanged. Loss of fluid from ECF alone would cause an increase in the concentration of red blood cells and an increase in hematocrit. However, we must remember there is also a fluid shift in this disturbance. Water moves from ICF to ECF. Since red blood cells are cells, water shifts out of them, decreasing their volume. Thus, the concentration of red blood cells increases, but their red blood cell volume decreases. The two effects offset each other, and hematocrit remains unchanged. What is the final state of the ECF volume? It is decreased because of the loss of ECF volume in sweat. Increased because of the water shift from ICF to ECF, or is it unchanged because both occur? The above figure shows that ECF volume is lower than normal, but why? Determining the ECF volume in the new steady state is complicated because although volume is lost from ECF in sweat, water also shifts from the ICF to ECF. Now let's do hypoosmotic volume contraction. You might want to listen to this part looking at the last picture on the previous slide in the top row of those 3 volume contractions. Adrenal insufficiency is our example. A person with adrenal insufficiency has a deficiency of several hormones, including aldosterone, a hormone that normally promotes sodium reabsorption in the distal tubule and collecting ducts. As a result of aldosterone deficiency, excess sodium chloride is excreted in the urine. Because sodium chloride is an extracellular fluid solute, ECF osmolarity decreases. Transiently, ECF osmolarity is less than ICF osmolarity, which causes water to shift from the ECF to ICF until the ICF osmolarity decreases to the same level as the ECF osmolarity. In the new steady state, both ECF and ICF osmolarities will be lower than normal and equal to each other. Because of the shift of water, ECF volume will be decreased and ICF volume will be increased. In hypoosmotic volume contraction, both plasma protein concentration and hematocrit will be increased because of the decrease in ECF volume. Hematocrit increases also because of the shift of water into red blood cells, increasing their cell volume. Now you might want to look at the bottom row of pictures on the previous slide. Let's talk about isoosmotic volume expansion, such as from infusion of sodium chloride. A person who receives an infusion of isotonic sodium chloride presents the opposite clinical picture of the person who has lost isotonic fluid through diarrhea. Since sodium chloride is an extracellular solute, all of the isotonic sodium chloride solution is added to the ECF, causing an increase in ECF volume but no change in the ECF osmolarity. There will be no shift of water between ICF and ECF because there is no difference in osmolarity between the two compartments. Both plasma protein concentration and hematocrit will decrease, that is, be diluted, because of the increase in ECF volume. Hyperosmotic volume expansion, such as from a high sodium chloride intake. Ingesting dry sodium chloride, for example eating a bag of potato chips, will increase the total amount of solute in the ECF. As a result, ECF osmolarity increases. Transiently, ECF osmolarity is higher than ICF osmolarity, which causes water to shift from the ICF to ECF, decreasing ICF volume and increasing ECF volume. In the new steady state, both ECF and ICF osmolarities will be higher than normal and equal to each other. Because of the shift of water out of the cells, ICF volume will decrease and ECF volume will increase. In hyperosmotic volume expansion, both plasma protein concentration and hematocrit will decrease due to the increase in ECF volume. Hematocrit also will be decreased because of the water shift out of the red blood cells, decreasing their volume. Let's now consider our sixth permutation, hypoosmotic volume expansion from SIADH. A person with syndrome of inappropriate antidiuretic hormone secretes inappropriately high levels of antidiuretic hormone, which promotes water reabsorption in the collecting ducts. When ADH levels are abnormally high, too much water is reabsorbed, and the excess water is retained and distributed throughout the total body water. The volume of water that is added to ECF and ICF is in direct proportion to their original volumes. For example, if an extra 3 liters of water is reabsorbed by the collecting ducts, 1 liter will be added to the ECF and 2 liters will be added to the ICF, because ECF constitutes 1/3 and ICF constitutes 2/3 of the total body water. When compared with the normal state, ECF and ICF volumes will be increased, and ECF and ICF osmolarities will be decreased. In hypoosmotic volume expansion, plasma protein concentration is decreased by this dilution. However, the hematocrit remains unchanged as a result of two offsetting effects. The concentration of red blood cells decreases because of dilution, but red blood cell volume increases because water shifts into the red blood cells. Cushing's syndrome. Cushing's syndrome is the result of chronic excess glucocorticoids. It can be caused by spontaneous overproduction of cortisol by the adrenal cortex or from the administration of pharmacologic doses of exogenous glucocorticoids. Cushing's disease is a separate entity, also characterized by excess glucocorticoids, in which the cause is hypersecretion of ACTH from the pituitary adenoma, which then drives the adrenal cortex to secrete excess cortisol. The symptoms of either Cushing's syndrome or Cushing's disease are the result of excessive glucocorticoids and adrenal androgens. Excess cortisol causes hyperglycemia, increased proteolysis, and muscle wasting, central obesity, round face, supraclavicular fat, buffalo hump, poor wound healing, osteoporosis, and striae, which is caused by the loss of connective tissue. Hypertension occurs because cortisol has weak mineralocorticoid activity, and because cortisol increases the responsiveness of arterioles to catecholamines by upregulating alpha-1 receptors. Excess androgens cause virilization and menstrual disorders in females. In Cushing's syndrome, the primary defect is in the adrenal cortex, which is overproducing cortisol. Accordingly, ACTH levels are low because the high cortisol levels feed back on the anterior pituitary and inhibit ACTH secretion. In Cushing's disease, the primary defect is in the anterior pituitary, which is overproducing ACTH. ACTH levels are elevated. The dexamethasone suppression test, in which a synthetic glucocorticoid is administered, can distinguish between these two disorders. In Cushing's syndrome, the primary adrenal defect with a normal CRH-ACTH axis, because the adrenal tumor functions autonomously, cortisol secretion is not suppressed by either low or high-dose dexamethasone. In Cushing's disease, ACTH and cortisol secretion are suppressed by high-dose dexamethasone, but not by low-dose dexamethasone. Treatment of Cushing's syndrome includes administration of drugs such as ketoconazole or metirapone, which blocks steroid hormone biosynthesis. If drug treatment is ineffective, then a bilateral adrenalectomy coupled with steroid hormone replacement may be required. Because of its different etiology, treatment of Cushing's disease involves surgical removal of the ACTH secreting tumor. Conn syndrome, or primary hyperaldosteronism, is caused by an aldosterone secreting tumor. The symptoms of Conn syndrome are explainable by the known physiologic actions of aldosterone: sodium reabsorption, potassium secretion, and hydrogen secretion. The effects of excess aldosterone are increased ECF volume and hypertension. This is due to the increased sodium reabsorption. Hypokalemia, due to increased potassium secretion, and metabolic alkalosis, due to increased hydrogen secretion. In Conn syndrome, circulating renin levels are decreased because the increased ECF volume, caused by the high levels of aldosterone, increases renal perfusion pressure, which inhibits renin secretion. Treatment of Conn syndrome consists of administration of an aldosterone antagonist, such as spironolactone, followed by surgical removal of the aldosterone-secreting tumor. Obviously, aldosterone is important in both sodium and potassium regulation in the body. Let's now consider when someone does not make and/or release sufficient amounts of aldosterone. Addison's disease, or primary adrenocortical insufficiency, is commonly caused by an autoimmune destruction of all zones of the adrenal cortex. In this disease, there is decreased synthesis of all adrenocortical hormones, resulting in decreased circulating levels of cortisol, aldosterone, and adrenal androgens. The symptoms of Addison's disease can be predicted on the basis of the known physiologic effects of these hormones. The loss of glucocorticoids, cortisol, produces hypoglycemia, anorexia, weight loss, nausea, and vomiting and weakness. The loss of mineralocorticoids, like aldosterone, produces hyperkalemia, metabolic acidosis, and hypotension due to decreased ECF volume. In women, the loss of the adrenal androgens, DHEA, and androstenedione results in decreased pubic and axillary hair and decreased libido. Addison's disease also is characterized by hyperpigmentation of the skin, particularly of the elbows, knees, nail beds, nipples, areolae, and on recent scars. There is hyperpigmentation due to negative feedback inhibition failure of the glucocorticoids, and thus ACTH synthesis and release is elevated. Increased levels of ACTH will lead to stimulation of melanocytes, as ACTH has a portion of the melanocyte-stimulating hormone within its protein. ACTH and MSH are both cleaved from a larger protein precursor known as POMC. ACTH, when cleaved from the larger POMC precursor, contains a portion of MSH, and thus can stimulate melanocytes in the dermis when in high concentration, leading to hyperpigmentation. Treatment of Addison's disease includes glucocorticoid and mineralocorticoid replacement. Less well-known fact, John F. Kennedy, JFK, he had Addison's disease, and that explains why he always looked like he had a tan, and that was part of the reason why women crooned over him. Time to focus to potassium. Internal potassium balance is the distribution of potassium across cell membranes. To re-emphasize, most potassium is present inside the cells, and even small potassium shifts across cell membranes can cause large changes in potassium concentrations in the ECF and blood. The effects of hormones, drugs, and pathologic states that alter this distribution of potassium are summarized on this slide. A shift of potassium out of cells produces an increase in the blood potassium concentration, and this is called hyperkalemia. A shift of potassium into cells produces a decrease in the blood concentration, and this is called hypokalemia. Insulin. Insulin stimulates potassium uptake into cells by increasing the activity of the sodium-potassium ATPase. Physiologically, this effect of insulin is responsible for the uptake of dietary potassium into the cells following a meal. Thus, in response to food ingestion, insulin is secreted by the endocrine pancreas. One effect of this insulin, in addition to stimulation of glucose uptake into cells, is to stimulate potassium uptake into cells. This action ensures that ingested potassium does not remain in the ECF and produce hyperkalemia. Deficiency of insulin, as occurs in type 1 diabetes mellitus, produces the opposite effect: decreased uptake of potassium into cells and hyperkalemia. When a person with untreated type 1 diabetes mellitus ingests a meal containing potassium, the potassium remains in the extracellular fluid because insulin is not available to promote its uptake into cells. Conversely, high levels of insulin can produce hypokalemia. What about acid-base abnormalities? Acid-base abnormalities often are associated with potassium disturbances. One of the mechanisms underlying internal potassium balance involves a hydrogen-potassium exchange across cell membranes. This exchange is useful because the intracellular fluid has considerable buffering capacity for hydrogen. In order to take advantage of these buffers, hydrogen must enter or leave the cells. To preserve electroneutrality, however, hydrogen cannot enter or leave cells by itself. Either it must be accompanied by an anion, or it must be exchanged for another cation. When hydrogen is exchanged for another cation, that cation is potassium. In alkalemia, the hydrogen concentration in blood is decreased. Hydrogen leaves the cells and potassium enters the cells, producing hypokalemia. On the other hand, in acidemia, the hydrogen concentration in blood is increased. Hydrogen enters the cells and potassium leaves the cells, producing hyperkalemia. Acid-base disturbances do not always produce a potassium shift across cell membranes, however, and it is important to note the following exceptions. First, respiratory acidosis and respiratory alkalosis typically do not cause a potassium shift because these conditions are caused by a primary disturbance in carbon dioxide. Since carbon dioxide is lipid soluble, it freely crosses cell membranes and needs no exchange with potassium to preserve electroneutrality. Second, several forms of metabolic acidosis are caused by an excess of an organic acid, for example lactic acid, keto acids, or salicylic acid, which do not require a potassium shift. When an organic anion, such as lactate, is available to enter the cell with hydrogen, electroneutrality is preserved. Adrenergic agonists can also affect internal potassium. And antagonists, well, that also can affect potassium imbalance. Catecholamines alter the distribution of potassium across cell membranes by two separate receptors and mechanisms. Activation of beta-2 adrenergic receptors by beta-2 agonists like albuterol by increasing the activity of the sodium-potassium ATPase causes a shift of potassium into the cells and may produce hypokalemia. On the other hand, activation of alpha adrenergic receptors causes a shift of potassium out of cells and may produce hyperkalemia. The effects of adrenergic antagonists on the blood potassium concentration are also predictable. Beta-2 adrenergic antagonists, like propranolol, will cause a shift of potassium out of cells, and alpha adrenergic antagonists will cause a shift of potassium into cells. Osmolarity can also affect internal potassium balance. Hyperosmolarity, increased osmolarity in the extracellular fluid, causes a shift of potassium out of cells. The mechanism involves water flow across cell membranes, which occurs in response to a change in ECF osmolarity. For example, if the osmolarity of ECF is increased, water will flow from the ICF to ECF because of the osmotic gradient. As water leaves the cells, the intracellular potassium concentration increases, which then drives the diffusion of potassium from the ICF to ECF. A simpler way of visualizing the mechanism is to think of water flow from the ICF to ECF as, quote, dragging potassium with it. Cell lysis can also affect internal potassium balance. This can occur from the breakdown of the cell membrane, which releases a large amount of potassium from the intracellular fluid and produces hyperkalemia. Examples of cell lysis include burn, rhabdomyolysis, which is the breakdown of skeletal muscle, and malignant cells being destroyed during cancer chemotherapy. Exercise also affects internal potassium balance. Exercise causes a potassium shift out of cells. The depletion of cellular ATP stores opens potassium channels in the muscle cell membranes, and potassium moves out of the cells down its electrochemical gradient. Usually the shift is small and produces only a slight increase in potassium concentration, which is reversed during a subsequent period of rest. However, in a person treated with a beta-2 adrenergic antagonist, which independently produces a shift of potassium out of the cells, or in those with impaired renal function, in which potassium cannot be adequately excreted, strenuous activity can result in hyperkalemia. As an aside, a potassium shift out of cells assists in the local control of blood flow to exercising skeletal muscle. Recall that blood flow in exercising muscle is controlled by vasodilator metabolites, one of which is potassium. As potassium is released from cells during exercise, it acts directly on skeletal muscle arterioles, dilating them and increasing local blood flow. On a daily basis, the urinary excretion of potassium is exactly equal to the dietary potassium minus small amounts of potassium lost from the body via extrarenal routes such as the gastrointestinal tract or sweat. The physiologic concept of balance is now familiar. A person is in potassium balance when excretion of potassium equals intake of potassium. If excretion of potassium is less than intake, then a person is in positive potassium balance, and hyperkalemia can occur. If excretion of potassium is greater than intake, then a person is in negative potassium balance, and hypokalemia can occur. Maintaining potassium balance is a particular challenge because dietary potassium intake is so variable, 50 to 150 milliequivalents a day, both from one person to another and from day to day in the same person. Thus, the renal mechanisms responsible for external potassium balance must be flexible enough to ensure that potassium excretion matches potassium intake over a very wide range. To accomplish this, potassium is handled in the kidneys by a combination of filtration, reabsorption, and secretion mechanisms as shown above. Filtration. Potassium is not bound to plasma proteins and is freely filtered across the glomerular capillaries. The proximal convoluted tubule reabsorbs about 67% of the filtered load of potassium as part of the isoosmotic fluid reabsorption. The thick ascending limb reabsorbs an additional 20% of the filtered load of potassium. Recall from the discussion of sodium reabsorption that potassium enters the cells of the thick ascending limb through the sodium-potassium 2-chloride cotransporter and then leaves the cell along either of two possible routes. Potassium may diffuse across the basolateral membrane through potassium channels to be reabsorbed, and potassium may diffuse back into the lumen, which does not result in reabsorption, but creates the lumen-positive potential difference across the thick ascending limb cells. The distal tubule and collecting ducts are responsible for the adjustments in potassium excretion that occur when dietary potassium varies. These segments either reabsorb potassium or secrete potassium as dictated by the need to remain in potassium balance. In the case of a person on a low potassium diet, there is further reabsorption of potassium by the alpha intercalated cells of the late distal tubule and collecting ducts. On a low potassium diet, urinary excretion can be as low as 1% of the filtered load. More commonly, though, in persons on a normal or high potassium diet, potassium is secreted by the principal cells of the late distal tubule and collecting duct. The magnitude of this potassium secretion is variable depending on the amount of potassium ingested in the diet and several other factors, including mineral corticoids, acid-base status, and flow rate. Urinary potassium excretion can be as high as 110% of the filtered load. The greatest attention should be paid to the handling of potassium by the late distal tubule and collecting ducts, because these segments perform the fine-tuning of potassium excretion to maintain potassium balance. Reabsorption of potassium in the proximal convoluted tubule and in the thick ascending limb is constant under most conditions. Again, this slide is telling us how external potassium balance is maintained. This has everything to do with potassium handling in the nephron.